Hello, my name is Steve Lewis. I'm a paediatric oncologist from Bristol. I'm just going to give you a brief rundown of neurofibromatosis type 1 as it relates to oncology in particular. So NF1 is a common and single gene disorder. It is inherited autosomal dominantly, and it's a predisposition syndrome, a condition for solid or hematological malignancy. It affects the whole body and it affects many different systems, and as a consequence it has a high morbidity and a high mortality. There are many opportunities when intervention can make a difference to patients with neurofibromatosis, and part of the reason for talking about this now is to point out how we should be acting for NF1 patients. So I'm going to give you an outline of the clinical features, some case histories, a little bit on the background, the diagnosis, genetics and clinical pathways, and at the end a very brief description of some of the physical interventions that have been considered recently. So NF1 is a neurocutaneous disorder. It's characterized by benign tumours, mostly neurofibromas, but occasionally people have malignancies as well. The complications are diverse, and the complications that happen in different individuals are variable, even when you have the same apparent genetic defect. It's common. Instances of 1 in 4,000 mean that in the UK, with a population of about 60 million people, there are 15,000 people who are affected, and the morbidity and mortality is high, as I've said several times. If you look at causes of death, there was a study in 2001 which reported 3,700 patients with neurofibromatosis, and the mean age of patients at death was 54 years compared to 70.1 years for the normal population. So it takes 15 or 16 years of life expectancy. The relative risk of malignant soft tissue neoplasm was 34-fold. Another study from Scandinavia looked at 70 adults with neurofibromatosis and followed these for 12 years, and in that period 22 of the 70 patients died, which is significantly more than might be expected for a normal population. The mean age of death was 62 years, and people died from malignancy and hypertension, all the consequences of it. Another study looking at both children and adults for a shorter period of time showed that in that period 40 deaths were seen, 18 of which were due to sarcoma. So clearly there is a significantly increased mortality for patients with neurofibromatosis. The risk of dying was found to be greater for male gender, patients who had many subcutaneous neurofibromas, facial plexiform neurofibromas, and patients who had itching as a significant feature. So NF1 was first diagnosed or first described in 1847 by Virchow, who described von Recklinghausen neurofibromatosis occurring in more than one generation, so indicating that this was a genetic disease. In 1918, the autosomal dominant pattern of inheritance was described, but not until 1956 was everything put together in a more systematic manner. So you had multiple cafe au lait spots and axillary freckling being described as main features. An estimate of the frequency was made at that time, and it was noted that the mutation rate was one of the highest for any human genetic disorder. In 1987, the gene was mapped to chromosome 17q11.2, and in 1990, the gene was cloned. It's a very large gene, has 60 exons, it takes 350 kilobases of genomic DNA, and mutations are found in almost every exon. And that, of course, presents a significant problem if you're trying to find the underlying genetic basis or confirmation of the diagnosis. If you look at the types of mutations that are seen in patients with NF1, they're very variable. They go from DNA losses or gains, point mutations, splice mutations, intragenic deletions and insertions, even whole gene deletions. And in addition to that, there is the odd patient who has mosaic forms, so that part of the body may be genotypically normal and others may have neurofibromatosis. neurofibromatosis. So a highly variable pattern of mutation seen in patients with NF1. It's just a picture of a patient on the left with normal fish for chromosome 17q, and there's normal chromosome 17, and there's one that's missing the neurofibromin region. So the gene product is neurofibromin. It's a big protein. It's a GTPase activating protein, a GAP protein, and it acts on RAS, GTP, adenylyl cyclase, and also on microtubules. There is alternate splicing that's seen, and so you get 4 different isoforms. The most common in the brain are the numbers 1 and 2. This is a very crude cartoon of one of the descriptions of how the gene might be working, and there are 2 main areas where NF1 may well be acting. One is on the RAS GTP pathway, and one is on this pathway which is primed by adenylate cyclase, ultimately leading to changes of gene expression either directly or through the MAP kinase pathway. Of course, this is quite an interesting possible pathway because it suggests that you might be able to modify the activity of neurofibromin using things like phosphodiesterase inhibitors, and this indeed has been something which has been explored recently in optic pathway glioma. So, neurofibromin has lots of ways of working. There are 4 isoforms and they're variably expressed, and there are many different mutations that can occur in the neurofibromin gene. So it's perhaps not surprising that you get a highly variable phenotype in affected individuals. But just going back, NF1 is a multi-system disease. It's a disease of the whole body, but particularly of growth and of learning, and it's a cancer predisposition syndrome. And ultimately, it causes a significant reduction in life expectancy. So what are the clinical features? It's important to at least acknowledge these. It's easy to look them up in a book, but it's probably appropriate that we just consider these now. So neurofibromatosis is diagnosed if you have 2 or more of the following features. 6 or more café au lait macules. In the prepubertal patient, that's more than 5 millimeters, and in the postpubertal, more than 15 millimeters. Here's some pictures of macules which would not be difficult to see in this patient. 2 or more neurofibromas of any type, or 1 plexiform neurofibroma. These are neuromas which appear later in life. This is a patient who's got a macule or a large freckle in the axilla and a plexiform neuroma here. Freckling in the axillary or inguinal region is another feature, and maybe one of the earliest signs. An optic pathway glioma is a characteristic feature. The presence of bilateral optic pathway gliomas does not mean that you necessarily have neurofibromatosis, but is of course more common in NF1. 2 or more Lisch nodules. Lisch nodules are these little brown flecks which are characteristically seen in patients with NF. A distinctive osseous lesion, and that can be one of several types. Sphenoid wing dysplasia, thinning of a long bone cortex, or a pseudarthrosis are fairly typical. So here's an example of sphenoid dysplasia, and on the right there's a picture of cortical thinning causing bowing of the limbs in another patient. An affected first degree relative. Well, of course, inheritance is autosomal dominant, and if you have an affected relative and you could fit, then clearly that's a strong indicator. Then there are additional features of neurofibromatosis type 1 which aren't necessarily diagnostic. They include short stature, a large head. At least 24% of patients have a head circumference which is more than 2 standard deviations above the norm, and a variety of unidentified bright objects on MRI. Unidentified bright objects, UBOs, or unidentified neurofibromatosis objects, UNOs. So these are UNOs. They're areas of high signal on T2 weighted images, which don't normally have mass effect. A significant number of patients have learning disability, although the type of learning disability is not necessarily straightforward. Crude IQ testing suggests that these children have an IQ which is well within the normal range, but many kids have other more complex difficulties which may need specific intervention. Hypertelorism is quite common. Hypertension is very common, particularly later on, and the incidence of pheochromocytoma is relatively high. Dural ectasia may cause destabilization of the spine because it may be so severe. A number of patients have been described with myeloid malignancy, and occasionally meningiomas, acoustic and optic neuromas, and hypoglycemia is reported. If you look at the order of appearance of these various characteristic features, cafe-au-lait macules and axillary freckling are amongst the earliest, Lisch nodules and then neurofibromas come later. Osseous lesions, if they're present, are usually seen in the first year. If you look at the number of patients who meet NIH diagnostic criteria, then about half of patients will have the necessary criteria to make a diagnosis of NF1 at 1 year, 97% by 8 years, and everybody by 20 years. So you'll see that it's not something which can be diagnosed at birth in all cases, and one needs to be cautious and on the lookout for NF1 in routine examination of neonates.